Okay, let's dive right in. The moment a baby is born, everything changes. For clinicians, a clock starts ticking. Those first 24 hours are this incredibly critical window for both mom and baby, where anything can happen. You've got to be sharp, you've got to be systematic, and you've got to be ready.
So picture this. The baby's out, the room is a flurry of activity, and suddenly your focus has to split in two. You have two patients now, and their conditions can turn on a dime. So where do you even start? What's normal, and what's a siren going off? We're going to break it all down, starting with the brand new arrival.
First things first, the newborn. We need to do a super fast head-to-toe checkup. We're basically looking for clues to see how they're handling life on the outside. Every little thing you notice in these first few minutes is a piece of the puzzle. So let's start at the very top, with the head.
Right away, you'll often see one of two things on a newborn's head, and you have to know the difference. Caput, just think of it as a cap, is this soft, puffy swelling that can cross over the suture lines on the skull. It looks a little weird, but it's no big deal and goes away in a few days. Cephalohematoma, on the other hand, is a bleed that's trapped, so it does not cross those suture lines. And here's the key takeaway, the one you'll see on exams: that trapped blood has to break down, and when it does, it releases bilirubin. That means a much higher risk for jaundice.
Okay, next, you're looking at how they're breathing. See any of these things? Nostrils flaring out, little grunting sounds with every breath, or seeing the skin suck in around the ribs? Those are all huge red flags. That's a baby working way too hard to breathe. But, and this is important, take a look at their hands and feet. If they're a little blue, that's totally fine. It's called acrocyanosis, and it's just their brand new circulation figuring things out. Don't mix those two up.
I'm going to say this loud and clear. If you see any signs of jaundice, any yellowing of the skin or eyes in that first 24-hour window, it is always a big deal. Always. Jaundice that shows up later can be totally normal. But in that first day, nope. That's a sign that something is wrong, and you need to figure out what it is fast.
All right, so after the initial check, every single newborn gets this little cocktail of protective measures. We give them a shot of vitamin K because they're born without the ability to clot blood well. We put some erythromycin ointment in their eyes to prevent infections. They get their first hepatitis B vaccine, and we do a critical heart disease screen with a pulse oximeter. It's a simple, routine protocol that makes a huge difference.
Okay, the baby is checked out and stable. Time to pivot all of our attention to our second patient, Mom. Her body has just done something absolutely incredible, and now we need a really good systematic way to check on her. And for that, we have a fantastic little mnemonic, Bubble LE.
This acronym is your best friend in postpartum care. It walks you through the 8 most important things you need to check to make sure nothing gets missed. It covers breasts, uterus, bladder, bowels, lochia, episiotomy, legs, and emotional status. It's the whole shebang. For now, let's zero in on the ones that carry the biggest risks.
The U for uterus is, without a doubt, one of the most critical checks. You want to feel her fundus, and it should be firm like a grapefruit and right in the middle of her abdomen. If you feel it and it's soft or boggy, that's an emergency. It means the uterus isn't clamping down and she's at major risk for a hemorrhage. Your very first action? Get your hands on there and massage it firmly. Now, what if it's firm, but it's pushed off to one side? The culprit is almost always a full bladder. Get her to the bathroom and it'll pop right back to the midline.
Next up is L for lochia. This is the normal bleeding that happens after birth, and what you really need to know is how it's supposed to change over time. It starts off as dark red, what we call rubra. Then, after a few days, it should lighten up to a pinkish-brown serosa. And finally, it turns into a yellowish-white alba. The big red flag here is if it goes backward, like if it was pink and then suddenly she's bleeding bright red again. That's a sign to investigate.
And the last E, emotional status, is so important. You have to know the difference between the baby blues and true postpartum depression. Look, the baby blues are super common. Mom feels weepy, overwhelmed, lots of mood swings, but it gets better within about 2 weeks, and she can still function. PPD is different. It's a darkness that sticks around longer than 2 weeks. It gets in the way of her being able to care for herself or her baby. And the biggest red flag of all, any thoughts of harming herself or the baby. That is a medical emergency.
All right, we need to shift gears and talk about the scariest, most dangerous thing that can happen after childbirth. We're talking about the #1 cause of maternal death around the world, postpartum hemorrhage, or PPH.
This is the number that matters, 1,000. A postpartum hemorrhage is now defined as losing 1,000 milliliters of blood or more along with signs of shock, no matter how the baby was delivered. To put that in perspective, that's a whole liter. It's a massive, life-threatening amount of blood loss.
So, what on earth could cause a bleed like that? Well, thankfully, there's a really simple way to remember the 4 main categories of causes. We call them the 4 T's.
Just look at this chart. It tells the whole story. A whopping 70% of all postpartum hemorrhages are because of tone, that boggy, atonic uterus we just talked about that refuses to contract. That's why your fundal checks are life-saving. The other causes are trauma, like a tear that's bleeding, tissue, meaning a piece of the placenta got left behind, and thrombin, which is a clotting problem. But seriously, if you remember nothing else, remember tone.
And here is a priceless clinical tip. Let's say you're doing everything right. You're massaging the fundus and it's rock solid, but there's still a steady trickle of bright red blood. You have to switch gears in your brain. The problem isn't tone. It's almost certainly trauma. There's a laceration somewhere that's bleeding and it needs to be found and fixed. So, the second you even think PPH is happening, there is absolutely zero time to waste. You need a game plan, a sequence of actions that you can fire off immediately to get things under control. Here's the playbook. First, screen for help, but do not leave your patient's side. If that uterus is boggy, you start massaging it hard. While you're doing that, someone else is making sure her bladder is empty, opening up the IV fluids wide, getting medications ready to make the uterus contract, and putting oxygen on her. In a real emergency, all of this is happening at once. It's controlled chaos. Now, about those medications. They are powerful and you have to know the safety rules. Honestly, this slide is absolute gold for your exams and for real life. There are 2 huge nevers you have to remember. You never give methylergovine or Mithergine to someone with high blood pressure, and you never give carboprost or Himabate to someone with a history of asthma. These are non-negotiable absolute rules. And then the crisis passes. The bleeding stops. The vital signs are stabilizing. But your job isn't done, not even close. Because a hemorrhage isn't just a physical event. It's terrifying. Your patient just stared death in the face. So as the adrenaline fades, what do? How do you pivot from saving her body to tending to her spirit? That shift, from the physical to the psychological, is every bit as important as everything else we just covered.